Of weeks ago, we did have a more formal presentation on marijuana. And here are some of my disclosures. I'm not getting any big pharma money or research money, just to let you know that. This is an important slide because we have our Martha Scarborough, who is your contact, and also Kelly Grant. Both of them are here in Atlanta. And the important thing about this, and I'm not sure why this is going on its own, but we'll, I think sorry, technical difficulties. Let me let you see Martha and Kelly's contact information. The thing that is very important for you to know is that Martha and Kelly are both very dedicated to finding the right treatment location for your patients and for their families. So they don't really, Caron is not first, the patient is first. So they're a great resource for other options, for other kinds of treatment resources in the community. And if you are not on their list, please reach out to Martha and make sure that she has your contact information. And like she said, some information about your practice, because we get lots of calls with all kinds of needs, and we want to make sure that the patient and their families get to where they need to be. So, last time we did talk a little bit about language, and I would like to just start with that again. Those of you who have already seen this slide, sorry, but we're going to review it really quickly. So cannabis is the genus. Remember back in biology where we had the phylum, genus, species, subspecies, all of that classification of plants and animals. Well, cannabis is the genus of particular flowering plants. There are 3 species. There's cannabis sativa, indica, and rudialis. So these are the 3 types of cannabis plants that people are familiar with. This slide is important because it helps you understand that marijuana and hemp are slang terms. They're not legal terms necessarily. They're not actually accurate in terms of understanding the biology of the plant. They are both from the same plant, the cannabis plant. Both of these subcategories produce the same products, the cannabinoids, which there are about 400 of them, and the terpenes, which are responsible for some of the subtleties like the flavor, the coloring, other kinds of properties that you might see in a plant. The important thing to understand is that hemp is the product that has been made legal by the United States. So it's legal in all 50 states to plant, harvest the hemp plant. It was originally introduced in this country many, many years ago, used to make ropes, used to make fibers for clothing, fibers for stationery, for paper products. And so it is very important as a crop, and it has been reintroduced and re-legalized, if you will. The definition that the government uses is that it has to have a THC, the tetrahydrocannabinoid, that is the psychoactive part of the cannabis plant, below 0.3%. It is allegedly having higher levels of CBD and some of the other minor cannabinoids. Marijuana has allegedly the psychoactive effects because it has higher levels of THC, but it can also produce CBD. So there have been lots, and our last discussion was about the differences and about some of the medicinal uses or lack of information about medicinal uses of the CBD product. What I do want you to understand and to take home is the idea that both of these, because they're not closely regulated, can make whatever claims they want, particularly the CBD and the hemp products. They can make whatever claims they want, but they're not FDA tested. They're not checked. There's no oversight that verifies that the claims they make are actually true, or that the amounts of THC found in the product are minuscule or not present. It is extremely difficult, as we discussed last time, to extract only the CBD from the plant, because there are 400 of these compounds in the plant, and it's expensive, it's time consuming, it takes a lot of sophisticated equipment. And so the only pure CBD is actually Epidiolex, which is a prescription medication that was approved by the FDA, that is written by prescription from physicians and dispensed via pharmacy and covered by medical insurance for specific problems like seizure disorders in young children. So the important thing to know is that if your patients are using hemp products or CBD products, there's a very good chance that they are actually going to have THC in them, which means they can have positive drug tests for pre-employment. They can get a DUI because there is THC. It's not a false positive. It's not a cross reaction. It's an actual positive. And one of the ways that many very smart and motivated entrepreneurs are selling marijuana in the state of Georgia and other states is by labeling it hemp or CBD. But actually we see in many of our patients very high levels sometimes of THC. So it's not a false positive. It can really mess things up if they're under probation, if they work in a drug-free workplace, or if there's some other reason that they get drug tested, because most people do not understand that, do not believe it, and they actually probably wouldn't be using the product if they thought that it was actually containing the psychoactive THC. So hemp-derived CBD is legal if it contains 0.3% THC or less. Marijuana-derived CBD is still illegal no matter what the percentage is of CBD or THC in the product. So just remember that you can still be charged with and convicted of having marijuana if it is not found that it is a hemp-related product. So today we are going to talk about having difficult conversations with patients and families. Now, all of you have had to have difficult conversations with patients and their family members. And really, it's not much different with discussing THC, discussing marijuana, discussing CBD. You need a little bit of information because your role is really often about education. And so that's where I want to focus on today. I want to focus on what are the facts, what is the information that you need to know to share with patients and their families so that they can make good decisions regarding the use of these products. It's important to understand your background, where you're coming from, how you feel about these kinds of things, because most of the time, these discussions can get heated. These discussions can have a lot of emotion around them, as most complicated topics do. So it's just important that you have a firm understanding about your biases, the way in which you want to talk to people about it, and where you're coming from, as with any discussion. But you need to know your audience. So most of the time, if we're dealing with a family, are we having a discussion with a family that's just interested? They bring this conversation up as part of therapy or as part of a family work that they might be doing, because it's in the news, because there's so much discussion about it in the media. So we have the curious family who are just wanting to know. I actually Googled curious family and found that the Sims programs have a family called the Curious Family. So here are some of the members of the Curious Family. So is this someone who is interested but does not have addiction in their family, and they're not worried about addiction in the identified patient or in other family members? So when patients are actually what we think of as having the disease of addiction and all of the different roles that family members play when someone in the family is active in their addiction, that's a different conversation. So knowing what they're actually asking is really important. We need to remember that if the person or someone in the family has the disease of addiction, that there are different sites within the brain where drugs have their action. We have the ventral tegmental area and the nucleus accumbens. And these are where dopamine, the pleasure chemical, is released. One of the things that's really important to know is that while some people prefer uppers and some people prefer downers, all of these release dopamine. And we have the 4 substances that, whether you like uppers or downers, you will like these because they release dopamine in both of these centers. So I used to have to just talk about 3 of them, but now we have to talk about 4 of them. So nicotine, upper, downer. We have marijuana, upper. We have marijuana as a downer. We have alcohol, and sorry, when I squished the slide, it looks like chocolate and alcohol became fused. Those are 2 separate things, although I think people do like chocolate martinis. But anyway, alcohol and alcohol. So all of these, whether you like uppers or downers, release dopamine and can therefore lead to relapse or lead an individual to think about maybe that doesn't release as much dopamine as I would like, but it reminds me of what I do like and therefore can make me crave what I do like. Heroin is the one that we had to add later, and heroin is here under morphine. I'm so sorry, but right under morphine is heroin. So didn't used to have to do this. And I remember a number of years ago when I had a patient that I had treated several years before for stimulant addiction, and they came in and they were addicted to heroin. And I thought, that just makes no sense to me because a stimulant has a very different impact on a person normally than does an opioid. Until I thought back to this particular slide and understand that in all reality, heroin also is the chameleon drug, like nicotine, marijuana, and alcohol. So we have these 4 drugs that release at either place. And this is one reason why this is actually an easier conversation to families where addiction is part of their history, because addiction is a brain disease. And we understand that it's a genetically inherited brain disease that is certainly impacted by access to drugs, stress, other kinds of driving forces that make the person more likely to try a particular type of medication or substance. But the problem is not the specific drug, it's their brain. Plenty of people can take their pain medicine without any trouble. Plenty of people can drink alcohol and not get into trouble. The problem is not an alcohol problem. The problem is a brain disease problem. And because of the genetics, because of the wiring in the brain, if you will, because of the way drugs impact the brain of people who are genetically predisposed to the disease of addiction, they can't use any of these substances safely. So they need to be careful about behaviors like eating or exercise or shopping or gambling. They need to be careful and aware of, maybe alcohol was the substance that brought me to the dance, but marijuana can lead me right back. So the problem is not the drug, it's your brain. So you need to know that you can't use any addictive substance or behavior without risk. So that's easy. You can talk to that family about no THC, no marijuana, no CBD, no hemp products, because these are going to potentially lead that person into either loving this new drug or being reminded and developing cravings for the substance that they prefer the best. So no matter what dopamine releaser is your dopamine releaser of choice, easy. No marijuana, no CBD, no hemp. So one of the ways in which I really want to talk to families, particularly those that are curious and wonder why, the recommendation is that nobody be introduced to substances under the age of about 26 or 27. And it has to do with brain development. So I'm not speaking, and the rest of the topic will not be necessarily at all about people who have the disease of addiction. The studies that I will cite, the references that are on the slides, are not done on people who have the disease of addiction. But one of the things that is important is that our brains as women continue to grow and develop and are not completely myelinated until we're 25 or 26. So we don't have a fully adult brain as women till we're 25 or 26. We don't have a fully adult brain as a man until we're 26 or 27. So this becomes a problem. And in this period of time, the adolescence, which is considered age 13 to 25, is the real important time when the brain is pruning, where pathways are laid down and important pathways are very much strengthened. Diet, exercise, sleep, not being exposed to drugs or alcohol. These are the ways in which we can protect the growing and developing brain. When we look at where marijuana affects the body, it's in very many important centers. So here's our addiction center, but here's a very important memory center. This is our hippocampus. This is our amygdala right here, which is our emotional memory part of our brain. Here's our cerebellum. This is the part of the brain that we used to think was just about balance and just about agility and other kinds of physical behaviors that have to do with movement. But we now also know that important processes of information are here. And in fact, there's some types of ADD that are actually found affecting the cerebellum rather than the left prefrontal cortex. So we have the prefrontal cortex, we have the movement and sensory center of the brain. We have the part of our brain that has to do with growth and development of spiritual and philosophical viewpoints here in our parietal lobes. We have the cingulate gyrus, which is a very important part of our brain that is necessary for shifting our attention. Right now, we're all focused on the slides or something. But if a tiger were to run into your room, then I would certainly not want to stay up here in this part of my brain asking, is that a Bengal tiger or Siberian tiger? And how are they different? And I can't remember. No, I want my brain to switch from being up here in my prefrontal cortex to back here so that my amygdala and hippocampus can get me safe. So it's very important that we have all of these areas of the brain, and they're so very important in so many processes in the body, particularly as kids grow and develop. This endocannabinoid system is there to reward them for doing all of the difficult things, the difficult tasks of growing up. It rewards them and encourages them to keep trying to do things that are so hard, like learning to walk or do their ABCs, or learning to do their times tables or play the violin. These skill sets take a lot of practice, and you're not incredibly successful the first few times that you do that. But the endocannabinoid system, which is our natural system for reward for those things, is there to help us keep being motivated, keep being encouraged, being excited to learn to play soccer and excited to do all of the things and continue the hard work of growing up. We also know that the pleasure center of the brain has receptors, both locations, for the endocannabinoids, our own internal substances that have a similar shape to marijuana. So when you smoke marijuana, now the amount of stimulus for all of these centers in the brain is way higher, to a greater degree than you ever see with people who are learning their times tables or showing up for soccer practice. This overstimulation leads to disruption of our body's own production of cannabinoids. That's why you can often see kids around puberty, sometimes earlier, and a lot of the patients that I interview certainly have started and been exposed to marijuana even earlier than 12 or 13. But around this point in life, they start to experiment with and be exposed to marijuana. Now, even if they don't go on to develop the disease of addiction, and most of them won't, only about 9% of the population who uses marijuana on a regular basis will go on to develop an addiction that will require formal treatment. But the important thing is that suddenly you do start to see the changes. You start to see kids that no longer are interested in doing their homework. They're not interested in going to sports practice or playing their musical instruments. They're not interested or rewarded to any kind of degree anymore for doing the usual things that they used to enjoy and be very active with. Their motivation goes down. They start to have problems with their memory. They start to have behavioral problems in school. The way they dress, the way they act, the friends they hang out with, all of these things begin to change. Unfortunately, many well-meaning providers will suddenly diagnose ADD. And one of the things that I often tell folks to think about is, in my opinion, if you've made it through elementary school and junior high, and now suddenly you have ADD, you're probably marijuana toxic until proven otherwise. And unfortunately, most pediatricians and child psychiatrists don't do drug testing. So suddenly they're put on stimulants, which can create a whole nother set of issues, when the problem is really marijuana and the endocannabinoid system being overwhelmed to the point that the child is no longer rewarded by things they usually like. So, so we see that this overstimulation produces the intoxication, and it alters the way in which the cannabinoid receptors respond. So now we can have withdrawal symptoms, and in vulnerable individuals, we can have the process leading to the disease of addiction. So here's this process of myelinization of the brain. And we see the areas that are blue are the areas that are first myelinated. So when you're little, you're getting myelinization here of the motor and sensory cortex and of the cerebellum, because you need to learn to walk and ride your bicycle and do a lot of those kinds of things that tend to be more physical. It's not until our late 20s and mid to late 20s that we get the full myelinization of the prefrontal cortex, our good judgment, our executive function of the brain. And that's an important thing. And when you expose a brain to marijuana, you are potentially going to rewire that brain so that it does not function nearly as well. We know that the prefrontal cortex is our braking system. This is what weighs and balances our decision, helps us delay gratification. But one of the things that we've also learned is that during adolescence, the nucleus accumbens, our reward center, now is fully adult. So the prefrontal cortex not, the brakes aren't there, but the pleasure center is. And now suddenly things like sex, drugs, rock and roll, all kinds of things are immensely pleasurable and very rewarding. And the kids don't necessarily have the good judgment to understand that maybe there is danger involved in some of their behaviors. So it's this combination of not having a good prefrontal cortex and having too much stimulation of the nucleus accumbens that the pleasure center sits in. So there was a nice study that was done at Northwestern and Harvard. They used MRI scans to evaluate 18 to 25-year-olds. So this is late adolescence. Remember, adolescence goes up to 25. These are not people who are seeking treatment or had the disease of addiction. They smoked marijuana at least once a week, and they compared their brains to people who had never smoked. They found that the nucleus accumbens, that reward center, was larger, altered in shape and structure. They also found the amygdala, the burglar alarm system, was larger and more dense. That's where we begin to see this connection between marijuana anxiety, marijuana with paranoia, and we see this learned behavior of an association with marijuana and pleasure, marijuana and relief, marijuana and sleep. The result was that they found these patients had decreased motivation, pleasure, and increased symptoms of anxiety. Again, these are not people with the disease of addiction. And the comment made by the authors said this study raises a strong challenge to the idea that casual marijuana use isn't associated with bad consequences. So even if they don't have disease of addiction, even if they don't have to go on to treatment, their brain may be changed in ways that continue to create problems. This is another interesting study that was done by SAMHSA, the National Survey on Drug Use and Health, and this is from 2018, led by Robert DuPont. So when they looked at students ages 12 to 17 who had no marijuana use in the past month, and then they looked at their use of other substances, they were using other substances, no doubt. But when the patient or the teen reported that, yes, they had used marijuana in the last month, again, not addiction, but use, we see that's associated with a whole lot of other substance use. And this is not an uncommon finding. And we know that use of alcohol, binge alcohol, heavy alcohol use, tobacco, and other illicit drug use can create lifelong problems, even though the individual may not have the disease of addiction. This was a very recent study, excuse me, not a very recent study, but it was just duplicated recently, and I needed to update this slide, so I'm sorry. Done at the University of Buffalo. Men who smoked marijuana, again, not addiction, but they had significantly less seminal fluid, lower sperm counts, the sperm were abnormal. They found that this adversely affected their fertility, and because THC is stored in the fat cells, it can have an effect for a very long time. So I can have a glass of wine, and in 8 hours, that wine is completely out of my system. Now, with some of our drug tests, we are able to see metabolites of that. So we can tell if somebody drank or had some alcohol over the weekend by looking at ETG and ETS, but ethanol isn't there. Unfortunately, marijuana is. And so even though the person may not be feeling the acute effects of marijuana, they're not high, they're not buzzed, what they are is continuing to have issues in their body, particularly their brain, which is mostly fat, particularly with sperm and other parts of the body. So fertility is not everything. And certainly for most of our young adolescents, they would prefer not to have that. But it is something that impacts men as they get older. And this is often a way to also approach the fact that, again, you don't have to have the disease of addiction, but you may have more complications in terms of fertility. So I think what I've tried to do is present some facts, help you think about ways in which, without a lot of emotion, without argument, to present facts and let people whose families are curious, individuals who are curious, we can educate them about some of the risks, including the disease of addiction. We can educate them, but we can also have a discussion based on facts and not, hopefully, on emotion. So this is the part where I really hope that we can all share, and we can have the opportunity to have a discussion, because we've all had these difficult conversations with patients. The techniques are the same, but I think understanding how to have these conversations, and I'd like to learn from you. So I'd like to open this up for questions or discussions now.
Thanks so much, Dr. Blank. That was great. Again, I wanted to remind the audience they can either use the chat feature if they have a question, or feel free to raise your hand and we'll turn on your video and you can ask it in person. I'll start us off. I received a handful of questions, so I can start us off with one. What are your recommendations around a family wanting to implement drug testing in their home? Should they use a CVS test? Should they use a lab? What type of recommendations would you have?
Well, it's a very common question. I know families are very concerned, especially if they see these kinds of changes in the behavior of their adolescent or their young adult. The test that you do, you need to understand why you're doing it and when you're doing it. The CVS test that you can buy for marijuana, for cocaine, for nicotine, those three are pretty good, in the sense that even though they have a high cutoff level, so they're not necessarily going to detect little slight use, but they will detect some use. There's not nearly the false positive that we see with amphetamines, that we see with opioids, where other medications, like if you're taking Wellbutrin, for example, and you do one of these screening tests, not a confirmation test, but a screening test with a little dipstick, you may have a positive amphetamine screen and you're taking Wellbutrin, because the structure that assay, excuse me, my tongue is tangled up today. The assay of that type of test is looking for a specific structure, which Wellbutrin has in that structure. So does Sudafed. So there can be false positives, there can be false negatives, because the cutoffs are pretty high. But for nicotine, marijuana, and cocaine, they're actually pretty good, because there's not a lot of cross reaction. But again, it's not going to tell you the little dose. And usually it's not helpful if the person is intoxicated. So if I come home from a party and I'm acting weird, then that's not the time for you to do the drug test. The time for you to do the drug test is about 8 hours later. So wait till the morning and then give them the drug test. At that point, it's now in the urine. It's gone through the stomach and the liver, and it's now being excreted in the urine, and you can see it. So timing is really important. If they're acutely intoxicated, then you need to use a breathalyzer, or you need to use blood to see, or saliva, which tells you what's in the system right this minute. If you feel like that you want a more extensive test, most labs can have reasonable drug testing. The problem is that for many, if you want to go to LabCorp, if you want to go to Quest Lab, the problem is that you have to have a doctor's order. You can go to any test now. You can walk in and say, I want a drug test, I want a hair test, and they can give you a pretty good a drug test, and you pay out of pocket. It doesn't go through your insurance, but that's another option that families can use to get a pretty good drug test. One of the difficulties is that sometimes the tests that are done at an emergency room or other locations, they have the Department of Transportation panel, which has very high cutoff levels. So if you're just using it on a regular basis and not at high levels, you're not going to pick it up. Number two, if they're looking for benzodiazepines, they're not going to pick up the ones that kids are usually using, like Ativan or Xanax or Klonopin. Those are specialty tests that, though they're benzodiazepines, they're not going to show up. Also, many of the opioids, like Kratom, which is a very specialty test that you have to have, but kids can buy that at the local gas station. So that opioid, many of the synthetics, like, sorry, my clock's going, sorry. Many synthetic opioids like OxyContin or fentanyl, these will not show up in those drug tests. So, generally, to get a really good GCMS confirmed drug test, you have to go to a place like Caron, Atlanta, and have them do a drug test, because they use a sophisticated drug testing that actually looks at not just is there marijuana present or not, but how much, and it's confirmed. So it's not anything else. They've identified that yes, this is marijuana. It's at this level. We can see next week that hopefully it's come down, because marijuana can stay positive for a number of weeks, sometimes even a couple of months. So if you're getting the CVS or even the one at any lab test, you're going to have some difficulty in actually knowing, is the level going down? Is the person still smoking? Was it coming down and now it's gone back up? You need the GCMS confirmation to know the exact amount, which is a very long answer to a simple question. Sorry, Martha.
No, I think that information is really useful. That actually, we get that question often from families and other clinicians that are interested in helping others decide what type of drug test to do. And on that note, I wanted to share with everyone, I don't know if this is helpful, but we have a prevention program at Caron Atlanta called Teen Intervene. And oftentimes we'll have the families implement drug testing in their home. And the feedback we've received from the teenagers that have participated is they actually like the excuse to give their friends, mom and dad are drug testing me, I can't smoke with you, I can't drink with you. That's actually they feel like it's a valid excuse to use versus the outdated just say no.
Right.
They definitely feel like that's something that they can use with their friends when trying to get out of a situation. I'll just go on to my next question if no one else has a question right now. do you know any common medications that people take that can react badly when mixed with THC?
So there are a number of medications. And if you are looking for a specific one, I would suggest that you look at Marinol, Marinol. Marinol is actually the pharmaceutical grade of it's marijuana. We've had it available to us since the 80s. I used to prescribe it when I had HIV and AIDS patients who had AIDS wasting, who were having trouble with nausea and vomiting. They have a whole list of drug-drug interactions that are created with marijuana. Also, if you look up Epidiolex, which is the new CBD only without marijuana, there's still a number of side effects and drug-drug interactions that can be dangerous and difficult. So if you're curious, I would look up those two and look at drug interactions, and you'll be able to see both over the counter as well as prescription medications. And there's a big list, too big for today. But yeah, there's a lot.
That's a great idea. Thank you. What is marijuana detox like, and how long does it last?
So first of all, most people don't believe there's withdrawal, but there is. And with the withdrawal for any substance that we have, whatever the substance or the drug does to the person when they're intoxicated, the opposite is what happens when they're in withdrawal. So for most people, they'll tell you, I use marijuana to relax when I'm anxious. I use it to help me sleep. I use it to chill. So when you see someone going into marijuana withdrawal, which can actually take a little bit longer than you would think, because it is still in the system, it's still in your brain, it's still in your fat cells. So it's a little bit longer than you would see with alcohol or with opiates. So it may be a week or two after you stop using marijuana, you start to see the person being agitated, irritable, they can't sleep. They can't eat, because if you think about what marijuana does for most people, they get the munchies. So now they lose their appetite. They can't concentrate. They can't relax. They feel very uncomfortable. Now, it's not dangerous like coming off alcohol where you could have seizures and so forth, but it is very protracted. It can last weeks to even a month or two. And there are a number of things that you can do over the counter to help with that. I usually recommend N-acetylcysteine, the letter N and then acetylcysteine. This is an over-the-counter amino acid. Usually 500 milligrams 3 times a day can really help with cravings for both nicotine, for marijuana, and surprisingly for cocaine. We also use time-release niacin. This is a little harder to find. Most of the crystalline niacin that you might have to take if you had elevated cholesterol or triglycerides, that gives you the niacin flush. It's very uncomfortable. You look for time-release niacin, and you take that again at 500 milligrams 3 times a day. I also tell patients that's the baseline. If you need to take a couple of extra doses through the day, if you're really having a hard time, these things can be really helpful. There's other medications. Sometimes we use gabapentin, which is a prescription medication. Sometimes we'll use an antidepressant to help them with the withdrawal. We may need to intervene to help them with sleep. Those kinds of things are really problematic, and the people can be not life-threatening, but very miserable for a number of weeks at the least.
Great, thanks, Dr. Blank. I think you covered this question in your presentation, but I definitely think it's probably worth revisiting. What has been your experience with individuals that have an addiction to alcohol but continue to use only marijuana?
Well, what I see is that their use of marijuana goes up exponentially. So they counterbalance. They are still looking for dopamine, and alcohol releases dopamine, marijuana releases dopamine. We'll also see their use of nicotine, their use of caffeine. Sometimes behavioral addictions start to escalate too, because your brain is looking for that dopamine. So when we're trying to get people to detox, when we're trying to get people into a sober place, we want them to stop stimulating their brain like that. Because as long as you continue with even a little flick of dopamine every time you smoke a cigarette, it's going to continue to keep your brain activated and in potentially a dangerous way. So I try and explain that to them. We will do drug tests. We'll look at what the levels are doing. We'll talk about what's the motivation and what's the mood state that they're trying to either enhance or change, and try and figure out what's the driving force. As I say to them, well, if pot isn't a problem for you, then we know alcohol is. You got the DUI, your wife's going to leave you, your boss is going to fire you. We know that. We know you can't use that. But what is it that marijuana is doing for you? And if it's not a problem, then just don't do it. And that's when we begin to be able to have the discussion of, okay, just don't do it for a week and come back and talk to me, or 2 weeks or a month. And we begin to see, yes, there's an addiction to marijuana as well. And that's another thing that, as we ship through addictions, we'll eventually get to the sugar addiction at the end of the road for most people. So you have to obviously, I hate the term, but meet them where they're at, and have the discussion about what is it doing for you and what is it potentially costing you, and look at it from that angle.
That makes a lot of sense. What are some of the most effective methods you have seen that can help someone with anxiety and also with depression?
Well, one of the things that I always tell my patients is that I would like to rule out a medical cause, because it's very embarrassing as a psychiatrist to be treating somebody for depression or for anxiety and find out, oh my gosh, it's a thyroid problem. Oh my gosh, it's an adrenal problem, the little organ that sits on top of your kidneys. Or even more embarrassing, it's a vitamin D problem. You have low levels of vitamin D, and that's particularly what we start to see this time of year as the days get shorter, that seasonal mood disorder, vitamin D levels not adequate, or B12 and folate levels. So I would either, obviously if they were seeing me, I would order those labs for them, or ask them to have their primary care doctor. And to do a real thyroid check, not just the TSH, which is actually not a thyroid hormone, it's a message from the pituitary to the thyroid, but I'd want the thyroid hormones, the T3 and T4 and antibodies, to just see, because anxiety can be caused by an overactive thyroid, anxiety can be caused by overactive adrenal glands, and cortisol, our stress hormone, too high. So we want to make sure that those more simple fixes and inexpensive fixes are taken care of. So I really want to see that, because you will be surprised at how many people can feel much better pretty quickly by getting those kinds of imbalances corrected without having to have a lot of medication. I honestly don't write a lot of psychotropic medications. I do, but if needed, but there's often other reasons that are much less expensive, easier fix that's going to help their general health. And so that's what I like to do. And I'd recommend that they go see their primary care doctor and get those levels really tested, because they may not need anything more than that.
Yeah, that's something great to remember. And just a reminder to our audience, today's session is recorded, I feel like that last little bit of information is so important, and we could all use a reminder of that. So I'll send out the link to everyone of the recorded session, just so you can review it and have it on hand to share with any patients, families, anybody like that. Just once again, wanted to kick it back to our audience. If anyone has any questions, feel free to ask. Otherwise, we can wrap it up a little bit early, 5 minutes early, if that's okay with everyone. Yep, I think that's it for questions. Thanks again for everyone participating. I will email everyone the link to the recorded session at the end of this week. And thanks again, Dr. Blank, for joining us. I really appreciate it.
Thank you. My pleasure. I appreciate your help, Martha.
Have a great week, everyone.
See ya.
Thanks. Bye.